We are live.
Yeah. Good evening. Considering the epidemic of keratoconjunctivitis that is going on in the country, length and breadth of the country, I should say, there is a red alert. So our President-elect Dr. Samar Basak thought it was appropriate to conduct a webinar to alert the ophthalmologist. Of course, we all know the signs and symptoms of epidemic keratoconjunctivitis, in which cases to intervene, what are the red flags, etc. So I invite Dr. Basak to start the session with an opening remark, followed by address by the President who has just joined in.
So thank you, Santosh. This is actually after reading a lot of WhatsApp group, and we see a lot of cases and isolation words we have to create. Isolation, I mean clinic, and a lot of confusion among the common ophthalmologist about the protocol and antiviral or no antivirals, hot compress versus cold compress, then the corneal involvement and antibiotic, which antibiotic, moxie, no moxie, a lot of confusions are there, and that is why it is very important, because we see the lot of complication as a tertiary center. So before that part, we should address that, so that common ophthalmology, and we should protect ourselves, our paramedical staffs and others. So that's why this webinar is, and I will call upon our speakers are there, and Dr. Harban shall already join. So sir, you say a few words.
Request Dr. Harban, our President, to say a few words.
I think it was a very good idea, Samar. I think, and we definitely need to make public aware. Particularly, I don't know how to reach to the chemists actually, which create a lot of havoc. And but at the same time, we have got a public forum in our ARS website. That is, some of can visit over there, and me and some were discussing to how to strengthen our public platform for the various information, like suppose somebody wants to know about the multifocal IOL or whether to go for flags or not, what type of a lesson should be done. And we wanted to strengthen that, and without the name of the author. So I'm sure this is the starting point for because this is just pandemic endemic which has happened, the starting point for that. But we are looking forward to having a very strong platform where public can be educated, and we can have the articles contributed by the various authors without the name, and they can be awarded or rewarded, that can be seen. So I think this is a very good beginning, and I congratulate Samar Basak to taken the initiative, and Santosh to starting it off. Thank you very much. I think we can straight away go to the scientific content.
Thank you so much, sir. I will introduce the speakers, and then we can go ahead with the scientific. We have a wonderful session ahead. Dr. Harban, our President, who is the Director of Delhi Eye Center and co-chairperson of Gangaram Hospital, will be chairing the session, along with Dr. Samar Kumar Basak, who is the President-elect and Director of Disha Eye Hospital. He is a cornea specialist himself. Expert panel will consist of Dr. Partha Viswas, who is the Vice President of AIOS, Dr. Savitri Sharma, who is an eminent microbiologist, ophthalmic ocular microbiologist, and Director Emeritus of Laboratory Services, LV Prasad Eye Institute. Dr. M. Vanati, who is the editor of Indian Journal of Ophthalmology. Dr. Nishat Hussain Ahmad, who is again an ocular microbiologist from RP Center for Ophthalmic Sciences. She is an additional professor there. And Dr. Tulika Chauhan from Center for Sight, New Delhi. Speakers are very eminent, starting with Professor Namrita Sharma, who is the chairperson of Scientific Committee, AIOS, and also the head of Unit 4, which is Cornea, Cataract and Refractive Surgery at RP Center, AIMS, New Delhi. She'll be speaking on infective conjunctivitis and overview. And that will be followed by Dr. Nikhil Gokhale, who is an eminent cornea specialist in Mumbai, and he heads Gokhale Eye Hospital in Mumbai. He'll be speaking on adenoviral conjunctivitis, clinical features and diagnosis. That will be followed by Dr. Somashila Murthy, who is a cornea specialist and currently the head of Shantilal Sanghi Eye Institute, Mumbai. She'll be speaking on management of adenoviral conjunctivitis, evidence-based guidelines. One important topic, that is red flags and complications, how to triage and how to manage. That will be taken by Dr. Srinivas Kera, who is the director of Darshan Eye Care, Chennai, and he is an eminent cornea specialist and an ocular surface specialist as well. Another important topic, prevention strategies in the clinic, will be covered by Dr. Samina Zamindar, who is ophthalmic quality control specialist, and she heads Zamindar Microsurgical Eye Center, Bangalore. And the webinar is supported by Ajanta Pharmaceuticals. I stop my screen share and I would invite the first speaker, Dr. Namrata Sharma, to go ahead with her talk.
So thank you, Santosh, for this webinar. Thank you, Dr. Basak sir, for thinking about it, and also Dr. Harbanslal sir for this, because I think this is what is the requirement as of now. I would be covering the topic broadly of infective conjunctivitis, and classically inflammation of the bulbar and the tarsal conjunctiva is seen, and it is commonly known as the pink eye. Now, it could be allergic, it could be infective. Infective could be viral or could be bacterial. Viral is common in adults, and the bacterial is the one which is common in children. The clinical features more or less remain the same, which consists of pain, redness, itching, foreign body sensation, watering, mild photophobia. There may be transient blurring, and if it is severe, there may be also lid swelling. Apart from this, there can be diffuse congestion of the conjunctiva, and if you avert the lids, there can be definitive findings which may be there, and congestion in the palpable conjunctiva. Now, virus classically affects the epithelium of both the cornea and conjunctiva, and then it is known as keratoconjunctivitis. And both RNA and DNA containing viruses will infect the conjunctiva. RNA viruses generally are responsible for benign forms of conjunctivitis, whereas the DNA viruses are responsible for more vision-threatening forms of inflammation. And adenovirus, which is, of course, the most common etiology of viral conjunctivitis, is responsible for 60 to 90% of the cases. Now, common DNA virus, which are generally responsible for conjunctivitis, are adenovirus and herpes simplex virus, apart from varicella zoster, EBV, cytomegalovirus, molluscum contagiosum, and even vaccinia and variola virus. And of course, RNA viruses, although they are rare, are as shown here. If you look at the conjunctiva, in cases of viral conjunctivitis, generally begins with unilateral onset, diffuse congestion of the conjunctiva, and which can spread to the fellow eye also. And the hallmark is follicles on the tarsal conjunctiva. Follicles are nothing but aggregates of lymphocytes surrounded by plasma and mast cells in the superficial conjunctival stroma of the conjunctiva, and they appear as yellowish white oval mound with dilated vessels which are present in the periphery. Apart from this, there can be conjunctival hemorrhages in the form of chemosis, membranes, and pseudomembranes. Then there can also be other complicated things with viral conjunctivitis, which I'm sure these speakers are going to deal with in more details. They may have punctate epithelial keratitis, anterior stromal infiltrates, or even pseudodendrites. Systemically, often there would be upper respiratory tract infection, and there may be a prodrome of fever or diarrhea and lymphadenopathy. I will not be dealing in detail with adenovirus because this is going to be dealt with subsequently. But important thing is that it is generally biphasic, and it has an infective as well as an inflammatory cause. And the patients are infectious up to 2 to 3 weeks after the onset. And it can be of various types. The transmission can occur, and the communicability is extremely high during the first several days and might last 2 weeks after the onset. And of course, other systemic features of viral affection may be there, like pharyngitis, follicular conjunctivitis, fever, and lymphadenopathy. Crusting may be classically seen in cases of pharyngoconjunctival fever, and an epidemic keratoconjunctivitis is in fact the most severe ocular adenoviral infection and may also be associated with keratitis. Epidemic keratoconjunctivitis will show features of diffuse hyperemia, mixed follicular and papillary reaction, and even subconjunctival hemorrhages may be there. And it is important to distinguish between pseudomembranes and true membranes. So pseudomembranes, which may be present with some forms of conjunctivitis, would generally lack blood or lymphatic vessels, and there would be membranes which are adhered to upper and lower tarsal conjunctiva and can be removed easily. Whereas true membranes, because they are formed out of coagulum beneath the epithelium, they are difficult to remove and they may induce bleeding. Subepithelial infiltrates may be there in these cases, and apart from this, there can also be other non-specific acute follicular conjunctivitis, which are not related to adenoviral keratoconjunctivitis. A chronic relapsing viral conjunctivitis can also occur, which can persist for years and it can relapse again and again. And hemorrhagic conjunctivitis is again, which can occur because of enterovirus type 70, Coxsackie virus type A24. And we've also reported that there can be superadded bacterial infection in these cases, especially with inadvertent use of topical steroids. Another differential that you need to consider in these cases is herpes simplex virus conjunctivitis, which is generally unilateral, has a shorter clinical course as compared to adenoviral keratoconjunctivitis. And classically, you will see typical lid and or corneal lesions in the form of vesicles, dendrites, and geographical lesions, which may not be present in cases of adenoviral keratoconjunctivitis. The symptoms remain the same, but amongst the signs, like I said, one classical feature may be that dendritic ulcers are present in these cases. This is just to show the pictures of the same. You can also have herpes zoster virus conjunctivitis, where you can see the vesicles which are also present on the skin. And the differential would also consist of allergic conjunctivitis. Some patients who use contact lens may have contact lens related complications, which may appear like conjunctivitis because of the presence of the red eye. Apart from this, chemical conjunctivitis and foreign body is something which again has to be ruled out. Then there can be what is also called as molluscum contagiosum, which classically affects healthy children and consists of chronic follicular conjunctivitis, ocular irritation, mild discharge, and they may be pale, waxy, or umbilicated nodule, which may be present and generally will require excision or curettage. Now, this is about other viral conjunctivitis, and they become important because their treatment is different. For instance, if it is varicella zoster virus, which is causing conjunctivitis and a flictanule-like lesion, then oral antivirals have to be given if keratitis is also present. Or if it is Epstein-Barr virus, which also has episcleritis, hemorrhages, keratitis, and uveitis, then they will generally resolve spontaneously, and you may not require any treatment. On the other hand, if it is variola and vaccinia virus, then you may have to treat with antiviral drugs topically. And CMV conjunctivitis, again, may be associated with chorioretinitis and may need no specific treatment. Now, you can also have bacterial conjunctivitis, which generally has rapid onset conjunctival redness, swelling of the lids, and a sticky discharge, unlike watery discharge, which is present in viral conjunctivitis. And symptoms will develop in the first eye and will spread gradually to the other eye as well. Apart from the eyelid chemosis, like I said earlier, there would be grayish or yellowish discharge, and there can also be crusting of the lids, which may be there, and surrounding skin may also get excoriated. Now, acute bacterial conjunctivitis may occur because of Staph aureus pneumoniae or strep pneumoniae or H. influenza. Hyperacute bacterial conjunctivitis will occur because of Neisseria, gonorrhea, and meningitis, and chronic bacterial conjunctivitis will occur because of Staph aureus, Moraxella, and gram-negative enteric flora. Atypical presentation may be seen in cases of bacterial conjunctivitis, which may occur because of chlamydia or Moraxella when it is non-exudative and persistent, and there may be mild redness. And because we do have a chlamydia testing facility at our center, many of the cases of conjunctivitis, especially the chronic ones, which don't resolve, are sent for chlamydia antigen testing. And apart from this, membranes and pseudomembranes may be there in Neisseria, beta hemolytic streptococci, or Corynebacteria. Investigations generally are not done for these cases, except for the purpose of research and for the purpose of knowing what the epidemic is due to, it happens every year, almost every year, especially during the rainy season. And as such, it is important to prevent the transmission and avoid complication And the mainstay remains the symptomatic relief for the patients. Now, I'm sure these are going to be discussed in detail, the management of conjunctivitis as such. I would just talk about the bacterial conjunctivitis, for which it is important to give cold compresses and also give topical antibiotic agents. For viral conjunctivitis, we classically they will not be benefited by topical antibiotic agents, but they are used only prophylactically to prevent a superadded infection. Now, word about role of antibiotics, they do speed up the healing in bacterial conjunctivitis, especially in cases where there is chlamydia or gonorrhea conjunctivitis. And oral antibiotics are indicated and have been used by some in chlamydia and gonorrhea conjunctivitis. The choice of antibiotic can be fluoroquinolone, sodium sulfacetamide, or trimethoprim polymyxin, and the duration is generally 7 to 10 days. This was a systematic review of 21 randomized controlled trials which looked at the role of antibiotics in acute bacterial conjunctivitis and clearly came to the conclusion that 53% there is a likelihood of recovery in proven bacterial conjunctivitis. So, as is logical, in bacterial conjunctivitis, antibiotics should be given in these cases. As far as the topical corticosteroids is concerned, in bacterial conjunctivitis, they seem to have a limited role. Although for very severe symptoms, they may be given, but only after you know what organism it is and only after you have sufficiently or treated cases of bacterial conjunctivitis. Now, NSAIDs again, although they will alleviate symptoms to some extent and will help, but generally they are not given because of the risk of the corneal melt. And there are, apart from this, other immunomodulators which have been tried more in viral conjunctivitis, which I think will be covered by the subsequent speakers. As far as the conclusion is that in cases of bacterial conjunctivitis, one has to treat with the antibiotics, but viral conjunctivitis, antibiotics have only a prophylactic role, and as such do not play a curative role in these cases. And these are some of the pictures of viral conjunctivitis from our center from the recent pandemic. And I'm sure Dr. Nishat from Ocular Microbiology Department, who's heading it, would be able to elucidate more, who's investigating this epidemic in our center. Thank you very much for your kind attention.
Thank you, Namrata, for this overview of conjunctivitis. Basak, do you have any questions at this time? Or any of the panelists want to discuss anything at this point in time? You're muted, sir.
So I think we can take the discussion at the end. That will be more useful.
Sure. So then we'll have Nikhil Gokhale. He's from Mumbai, as I already introduced. He's going to speak on adenoviral conjunctivitis, clinical science and diagnosis.
So you can see my slides?
Yes, Nikhil.
Yeah, so I'll thank AIOS and Santosh for giving me this opportunity today. In fact, the last 2 days, I tried to revise about some of the features of adenoviral conjunctivitis. So the adenovirus can present as a spectrum right from a very mild conjunctivitis, as you can see on one side of the image. And on the other side, you can have an extremely fulminant and very severe sort of conjunctivitis. As Namrata mentioned, we could have either an EKC sort of picture, a pharyngoconjunctival fever, or a simple follicular conjunctivitis. And I'll just go through some of the clinical features of these 3 variants. So the adenovirus has 7 species, A to G, and then there are serotypes for each of the species. So typically, the EKC is caused by the serotype 8 of the D species. The pharyngoconjunctival is caused by the B species. Serotype 3 is the most important. And the simple follicular conjunctivitis again can be because of another types. In general, as we all heard, the conjunctivitis will present with red eye, watering, discharge, swelling, foreign body sensation, photophobia, blurred vision, and painful lymph nodes. And the spectrum, as I said, could be very mild to extremely severe. Looking at epidemic keratoconjunctivitis, it's the most severe form of adenoviral conjunctivitis, which is most commonly seen in adults. There is usually a history of conjunctivitis that you will find either in close contacts or maybe in the family or friends. There may be a history of going to healthcare facilities, which can be a source of infection, or in common areas like swimming pools and so on and so forth. Usually the incubation period is about 10 days, and the disease can last from anywhere from 1 week to 3 weeks, depending on the severity. Usually the eye is contagious as long as the eye is clinically red and there is active inflammation. The process is usually unilateral but becomes bilateral in about 70% of the patients, and it's usually milder in the second eye when it does develop. At presentation, typical picture would be of follicular conjunctivitis, preauricular adenopathy, which is often tender. You might get subconjunctival hemorrhages, and as Namrata mentioned, you will get membranes. In some of these patients, maybe 25 to 50% of patients may have pseudomembranes, and very severe inflammation with true membrane formation can also be there. Some of the patients, because of the extreme grades of inflammation, may have large epithelial defects or a gray-white corneal epithelium at presentation. Usually, over a period of a week, the conjunctivitis starts to resolve, and then these patients will then come sometimes with foreign body sensation. And what you can see in these patients, they would have epithelial keratitis. The punctate keratitis and the foreign body sensation will then resolve over a period of a week's time and then lead to formation of subepithelial infiltrates. And this happens in about half the patients of epidemic keratoconjunctivitis. And now typically of a blurred vision. Most patients will have a resolution of these subepithelial infiltrates over several months to a year. However, an occasional patient may show permanent scarring with irregular astigmatism. And a very small percentage of patients with severe inflammation, subconjunctival fibrosis, and dry eye. So typically, there is the first phase of disease is infective phase, where you have a lot of viral shedding, and you will have a cytokine of cytokines. It infection, you see response to viral antigens, and then you have the subepithelial infiltrate. Look at these infiltrates, they're pretty common. So these infiltrates are basically an accumulation of white blood cells around the capsid protein, which is absorbed into the subepithelial area in the active phase of the disease. So typically during the hepatitis, the adenovirus invades the epithelium, percolates through the basement membrane and the Bowman's membrane, and there is an involvement of the keratocytes, which then release inflammatory mediators such as the CXCL8, which is basically attracts a lot of neutrophils, and that is what you see in a subepithelial infiltrate. So it's basically the capsid protein, which is probably an inactive antigen around which you have inflammatory cells. Now, whenever you give any sort of anti-immunosuppressive agent like a steroid, cyclosporin, or a tacrolimus, it inhibits the white cells, and these white cells will disappear. That is why we call them infiltrates rather than scars. And the only problem is that the capsid protein continues to stay in the anterior stroma. And once you stop these drugs, they come back with an equal zest, and you will have a recurrence of the disease process. Of patients, as I said, if they continue to keep having cycles of this type of treatment where there is a waxing and waning of the subepithelial infiltrates, they might develop chronic scarring, irregular astigmatism, and a drop in the visual clarity. The OCT can be helpful. The top picture is in the when the subepithelial infiltrates, you can see the Bowman's membrane is intact with the presence of inflammatory pathology in the subepithelial zone. And the occasional rare patient who does develop scarring, you can see that the Bowman's membrane is disrupted. there is scarring in the anterior stroma, and there is epithelial remodeling. And most of these patients will have irregular astigmatism when you do a corneal topography. Luckily, the other two variants of adenovirus, that is the pharyngoconjunctival fever and the simple follicular conjunctivitis, are much more milder. The conjunctival fever is more common in children. And again, you might have outbreaks in school, in health facilities, swimming pools, etc. The incubation period is about 5 to 12 days, but the symptoms usually last for less than a week, unlike the EKC where they can go on from 1 to 3 weeks. It usually by the other eye is quickly involved in 1 to 3 days. The presentation is again a follicular conjunctivitis with adenopathy. However, they will also have systemic features in the form of fever, sore throat, rhinitis. They could have pulmonary symptoms and so forth. Most of these cases are self-limited, evolve into serious problems like we see with the EKC. Patients who have simple follicular conjunctivitis again have basically an acute follicular conjunctivitis, but again no complications and no systemic features, unlike the pharyngoconjunctival fever. Looking, we do have laboratory diagnosis. However, they have very limited role in most of our clinical day-to-day practice. They could be in the form of viral cultures, polymerase chain reaction, whole genome sequencing. One of the tests that has been used in clinics in practice has Adeno detector and the Adeno Plus, which are rapid screening tests, which can be done. However, the problem is that despite their high specificity, the sensitivity is pretty low, maybe 30 to 50%. So a negative test does not definitely rule out an adenoviral infection. And a conjunctival cytology is another that could be done in the laboratory. I think clinically, when we see a patient with a viral conjunctivitis or what looks like a viral conjunctivitis, two questions come to mind. One, whether this is an infectious pathology or a non-infectious pathology. And the second question that comes to mind is, if it's an infectious conjunctivitis, what infection? So therefore, when we are looking at treating these patients, I think we need to rule out all the other non-infectious pathologies which might be treated better off with steroids or other drugs, and where the behavior is very different from an adenoviral infection, but they can be equally confusing. So a patient allergy, tenular, rosacea, immune-mediated inflammation, patients with ocular surface disease, contact lens red eye, and toxic conjunctivitis. These are all conditions where a naive ophthalmologist is likely to be confused sometimes with an evolving conjunctivitis is having redness, but not all those typical features have evolved at that point of time. And when, as Namrata said, we need to consider other etiologies of conjunctivitis as well and try to figure out so that we know whether we should be giving antibiotic, antiviral, or just lubricants alone. In the next 2 minutes, one or two of these etiologies. The microsporidial keratitis is what we see very often in monsoons. The simple thing to remember is that if you have a red eye with white dots, it's microsporidial. In adenoviral, it's red eye, which is followed about 2 weeks later by the white subepithelial infiltration. Help us a simple clue to differentiate them. And they have a typical raised stuck-on appearance, which is very classical. And once you see them, I think we can not confuse with them. During the COVID era, I think we had a lot of patients in with red eye, which was virus or conjunctivitis. And response, you can have punctate staining, but usually the systemic symptoms may be there, though COVID conjunctivitis could be the presenting feature of COVID-19. And that is something that we have to keep in mind, possibly even today. Namrata mentioned about the hemorrhage, extremely contagious and starts off virtually simultaneously or bilaterally with short incubation period, and hemorrhages is what is predominantly seen. Again, we've seen outbreaks of this quite often. And the herpes simplex, I think one of the giveaways is that if you have vesicular skin lesions, the pathology as well as the presence of conjunctivitis with dendritic or corneal involvement can help us to differentiate herpes simplex. And sometimes we have patients who come into the clinic with chronic punctate keratitis with a red eye, with follicular response, and it's very difficult to figure out what's happening. keep in mind, of course, the adenovirus. The herpes is again the herpes simplex and zoster is something that we need to keep in mind. The chlamydia and the molluscum are more chronic lesions, and that will help us to distinguish them. The other common condition is sometimes you can get drug toxicity, like we see with, where again you will get a follicular reaction with a red eye, which is often again chronic, not really acute process. And sometimes when you have these nummular regions, you can figure out what type of pathology is there based on some of these points that I've mentioned in this chart. Take-home message would be that I think we need to have a good history and clinical examination. That's the foremost clues that it can offer us to diagnose adenoviral correctly. And we need to closely follow them for any problems, complications, and treat them accordingly. And I think patient education, education of staff and our doctors is very important so that we don't spread the disease further. Follow all the hygienic instructions, and equipment disinfection is something which is of utmost importance that we should not forget about. Thank you.
Thank you, Nikhil, for a very wide, comprehensive coverage of adenoviral conjunctivitis. I think we have a record number of viewers this time, more than 1,000 across platforms. Samar, I think everybody was waiting for this webinar, it seems.
Yes, yes.
Yes. So we'll go to the next speaker then.
Yes.
Somashila, you're on.
Yes, I'm here.
You can start sharing your slides. Somashila is an export to Mumbai from Hyderabad. She heads Shantilal Sangya Institute in Mumbai, and she's going to speak to us on evidence-based management of epidemic keratoconjunctivitis.
Thank you very much, Dr. Santosh, and thank you for having this very, very current and required webinar. Am I audible?
Yes, yes.
Okay. So my role is to take the faculty and the audience through the management of epidemic keratoconjunctivitis, but based on evidence, what is published. So this may not be exactly mirroring how we all practice, but this is what is published and what are the level of evidences that we have. Of course, I have no financial disclosures. I may be mentioning some products or some names, but I don't have any financial disclosures in them. So what is known has been covered by the previous speakers, Dr. Namrata, and also an extensive coverage by Nikhil on the entire clinical part of the subject. And also Dr. Namrata had talked about the management for bacterial conjunctivitis. So my role being to consider what is the management for the EKC, that is epidemic keratoconjunctivitis, which is due to adenovirus. So I'm going to stick to that. So only one thing that to highlight that although we say that it's self-limiting, we must remember that there are certain subgroup of patients where there can be serious complications, which can include symblepharon or scarring due to the nummular keratitis aspect and astigmatism. And of course, you can have side effect of steroids. So when we talk about evidence-based, I always remember this pyramid where at the bottom of the pyramid lies all our editorials, the anecdotal or expert opinion and case series and so on. And at the top of the pyramid are the systematic reviews, which are really very hard to do. But definitely in terms of conjunctivitis, because the numbers are huge, we can consider randomized controlled trials or cohort studies. And we are looking at least level 2, which is randomized controlled trials, and level 3 evidence. That is what I'm looking at in order to share that with you. The case series, case reports and all, we will not be discussing as evidence-based approach. So this is just the details of what each level consists of, which I won't be going through. So to discuss how reviewing literature will help us in managing our patients, we must know what does literature say, and then secondly, what should we interpret from literature? How can we use this evidence to guide our practice? So when I went through, all of us know traditionally that most practitioners and most of us who have gone through the books and who are very pragmatic would say that there is no need of any medication for conjunctivitis. Yes, it's true that none of the medication available can actually kill the virus completely. So there's no virucidal agent, which is a fact, for adenovirus. So therefore, there's no FDA-approved curative medication available so far. Also, the second part is that we know obviously that antibiotics will not help in treating the virus, the viral part of it. As Dr. Namrata mentioned, that we use it more as prophylaxis to prevent other problems. So there is no evidence that exists about the utility or the superiority of any topical antibiotic. I would go one step further and say that, and there are studies also to show that there's an unnecessary cost and an increase in community resistance when we use antibiotics. So should we really be using an antibiotic in a disease that primarily does not need it? So then what should we use? So of course, everybody agrees and there is enough. Well, again, it's not randomized controlled trials, but probably just sheer common sense that we should use supportive therapies such as chill, artificial tears, and cold compresses. And very, very important, and this has been proven beyond doubt, that there should be instructions, very clear instructions on infection control, as Nikhil has highlighted. So avoid the spread via fomites, avoid the spread via respiratory secretions. And we must remember that there are also asymptomatic carriers. So in the family, you might have some people who don't seem to have the disease, but they would be carriers. So we have to be aware of this. Now, coming to the first drug or drug combination, which actually shows promise and has enough randomized controlled trials that have been conducted, is povidone-iodine. We know that povidone-iodine is an antiseptic agent. Luckily, it has a broad spectrum, both on, of course, bacteria as well as on viruses, which includes both the enveloped and the non-enveloped. The adenovirus is a non-enveloped virus, meaning that it is so recalcitrant to most of our sterilization processes that it can stick to plastic, it can stay on our equipment for even up to 30 days. So luckily, povidone-iodine can act against it. It actually doesn't have any other role, but then it just reserves iodine, which it's toxic to the cells and inhibits the enzymes. That's how it works. So there are adequate studies on in vitro, which have shown its efficacy more against the extracellular, also against intracellular human adenovirus. So what it seems to be, what evidence says is that, yes, povidone-iodine definitely has a role in killing the, or in sort of causing destruction of the virus. Interestingly, there's a World Iodine Deficiency Day in October, so even humans can be deficient in iodine. The other advantages include that we are all very familiar with it because we use it as prophylaxis in cataract surgery. It's the cost is low. It's been, so anecdotally also, it's not the evidence that people have been waiting for, but we know that a lot of practitioners are using it in concentrations which can be diluted. And even a single application when the patient comes to the clinic with conjunctivitis, anecdotally, people have said that they have seen that it works better. However, it has a side effects. It stings like anything on instillation, and it can also cause allergic reactions, some of which can be serious as well. So the top 5 studies that involve the use of povidone-iodine. So these are the ones which have good designs. These are all randomized controlled, they're double masked. And all of them, you have used 2 treatment arms. Some of them have just used a vehicle, which could be the vehicle of the drug, or they have used artificial tears and compared against that. The one limitation of all of these trials is that they have all used povidone-iodine with dexamethasone. And a couple of studies do have a financial disclosure, whereas the other 2 don't have. So what are the results of these studies? So these are well-designed studies. The results say that of the 4 RCTs that I went through, 3 had positive outcomes. They said positive outcome. It meant that the daily topical application of povidone-iodine combined with 0.1% dexamethasone, that's what the molecule they were studying, had a better result than when they used it with the control alone. They also, one of the study compared povidone-iodine dexamethasone combination with dexamethasone alone. And they said that this combination worked better than dexamethasone alone. So, however, using povidone-iodine alone did not seem to prove to be as efficacious as using the combination, which is obvious because dexamethasone will work for anti-inflammatory control, and the povidone-iodine hopefully will kill the virus or will be virucidal. Interestingly, at the end of the study, when they checked the viral loads, they saw that there was no difference between the 2 groups. So the viruses are still present in both the groups. And there was no difference in future subepithelial infiltrates popping up. So the nummular keratitis stage using povidone-iodine with dexamethasone did not seem to be beneficial or protected. So the main efficacy that they looked at was a faster resolution, 3 to 5 days, as compared to 2 weeks or something like that without its use. And this was, and the rapidity of relief, as well as the patient symptom load and all of the other parameters that you would want the patient to benefit from was much more rapid in this combination. So those were the conclusions of these RCTs. Coming to another topic, which I'll go into very little, I'll just scratch the surface, is about topical corticosteroids. Most of the preferred practice guidelines, if you read, say, for example, the American Academy guideline, discourage the use of topical steroids for mild cases. And Nikhil has very clearly elucidated how the viruses stay on, and because of the inflammatory cells being knocked off by the steroids, the viruses stay active, and then later when you discontinue the steroids, they start proliferating. And therefore, the nummular keratitis stage recurs again and again. So that's a reason to discourage topical steroids, at least for mild cases. The risks, apart from prolonging the adenoviral infection per se, you can also have worsening. If it was herpes simplex virus, it'll become worse for sure. And of course, the routine side effects of steroids, which I need not mention in this group. So role of topical corticosteroid is there, but it is limited. So where is it indicated? Again, there is no level 3 evidence even, meaning there are no case control studies. But this is sort of a preferred practice guideline. It's American Academy has released that, which says that you can use it for the stage of punctate epithelial infiltrate, the subepithelial infiltrates that happen in the acute phase. The patient is very symptomatic. The uses that almost everybody's agreement with is when you get pseudomembranes, when you have severe manifestation, for example, chemosis and inflammation, periorbital, preseptal inflammation, and of course for nummular keratitis, where we all know that it has to be used in slow taper and for a prolonged duration of time in those cases. Coming to other therapy, the role of NSAIDs, there was no RCT or no level of evidence beyond level 4, like the top 2, the bottom 2 in the ladder that I showed you. It can be used as supportive therapy, the utility of which was not proven. So you can give or take, probably not use it at all. Cyclosporin A and tacrolimus, again, no case control studies, leave alone RCT. But it is an agreement that you can use it for SEI. Again, there is no case control study. There are only a series of cases that have been published. And you need prolonged course of therapy is what all the literatures agree. Antivirals, there is absolutely no role. This has been emphasized again and again. There are certain new agents. One is called ozonized oil, which they have used with Tobadex because Tobadex is available. And in a good study that seemed to have been conducted well with no financial disclosure, seem to have worked well. And another agent that I saw was N-chlorotaurine, which apparently shortened the disease course significantly. And this is not a steroid, so it is something else. So perhaps it may be protective for the nummular keratitis stage. So in a nutshell, what have I learned? So of course, symptomatic measures, tears, compresses, etc. for all, which is what we all do, infection control, which is what we all explain. And based on this review literature, it seems like, so level 2 or level 3 evidence, meaning not on the top tier evidence, but there is some evidence that povidone iodine with dexamethasone may be effective. We have gone through the indication for steroids and we have gone through the indication for cyclosporin and tacrolimus as well. So what we have is a sort of a level 3-ish or level 2 evidence for the use of povidone iodine. Unfortunately, the dilution and dosage, all the studies have different dilution and dosage, so we don't know that yet. That's it from my side, Dr. Santosh. Thank you very much.
Thank you very much, Somashila. Very comprehensive and nice as usual.
Thank you.
Can share, yeah. The next, of course, is Dr. Srinivas Rao. Most of the cases of EKC resolve on their own, but there are certain red flags. And those are the ones that we need to be aware of and refer as appropriate or intervene as appropriate. So Dr. Srinivas Rao is going to address these issues. What are the red flags? How do you triage them? When to refer and how to manage?
Thank you, Santosh. And thank you again for the invitation to speak today. The adenoviral structure is on the bottom right of your slide. We've heard about this ad nauseum in the first few talks. But unfortunately, in a meeting of this type, there will be some repetition. One of the reasons why this virus keeps coming back again and again and again is because there are 7 species, 50 serotypes, and 70 genotypes. So it's not difficult to imagine why the immunology keeps changing. And therefore, we do keep getting these epidemics without really any population resistance in the long term. The ones we are interested in are the B and D strains, and 8 and 19 are the ones that produce EKC. The other problem with this virus is that it's very unusually stable to physical, chemical, and pH changes. Viral infections typically tend to be self-limited because the virus needs to take over the cellular machinery to propagate itself. Basically, the natural history is it multiplies in the cell and then it tries to spread to the other hosts. And the end stage will either be that it kills the host due to cellular damage, or the host immune response succeeds in getting rid of the virus. And in about a week or so, everything gets back to normal. Now, basically, in the adenovirus, sometimes there are changes in the molecular structure of the virus in the hexon, the fiber, and the penton, which are indicated in the drawing there. And the cell damage occurs from both the viral effects as well as the host immune response. As we just heard, the steroids can help in reducing the inflammation, basically by modulating the immune response on the part of the host. The reason why some of these patients have very severe disease is because some strains of the virus tend to be pro-inflammatory, and as yet we don't really understand how the host responds to the virus in an individual patient. The nature of the virus is generally to reduce the host inflammatory response. It tends to inhibit the cellular apoptotic mechanism so that it can reside and propagate in the cell, and this allows viral replication. Sometimes there is a mutant pro-inflammatory viral strain that comes up in which this ability to mute the host inflammatory response is lost. And these are the patients in whom, and these are the epidemics in whom we see the very severe versions because it's no longer hidden. The host is able to, put up a violent immune response, and there is extensive damage on the surface. So we see global congestion and tearing, and typically we see the follicular response. You may see regional lymph nodes, and it may be associated with systemic symptoms as well. The bacterial tends to be slightly more localized. There is discharge, which is mucopurulent, and there is a papillary response, and there are usually no nodes and often no systemic symptoms. Sometimes in a busy clinic, in the context of an epidemic, when we are kind of tuned to seeing these patients again and again and again, you see a patient like this with a quiet eye in one eye and the other eye having this kind of congestion. You casually look at the bulbar conjunctiva, it is congested. The palpebral conjunctiva is, however, not. This should be a red flag, the unilaterality, the fact that the palpebral conjunctiva is not abnormal. And then if you look a little closer, you can see the fibrin. And if you look at the AC, you will see the AC reaction. And this is an iritis masquerading in this context of an epidemic as an adenoviral conjunctivitis, which is not difficult to miss in a busy clinic, also because you don't want to touch these patients too much. You want to get them out of your clinic quickly. So in the initial stage, you can see the corneal damage, the SPK. The virus is actually infecting the cells with cellular damage on the corneal epithelium. This is in the first week, and it usually clears with time. So if you see this kind of staining, maybe it is not wrong to put a little antibiotic in the eye for the first few days, because it can help protect this from a secondary infection from other agents. These typically appear at about 2 to 3 weeks, the subepithelial infiltrates. And like Nikhil mentioned, if the damage is at the level or above the level of the Bowman's membrane, you typically see this kind of a subepithelial infiltrate, which is a collection of the immune cells. And there is, if it goes beyond the Bowman's layer, and then if it causes collagen disruption, then you can get this kind of scarring. These are flat uniform lesions, and this was very well shown by the OCT he showed as well. You can get these membranes in adenoviruses. If they are pseudomembranes, you can peel them from the surface without much bleeding from the underlying conch, because this is just a condensation of the fibrin-rich exudate. But a true membrane is basically when there is extensive cellular necrosis and the reparative response is forming the membrane to try and seal off the tops of the necrotic layer. And this is a coagulum of exudate over the mucosal substantia propria. And if you try peeling this, it will result in bleeding and it will reform even before the patient leaves your clinic. The membranes have been seen. The ultrastructure in studies have been shown to be a collection of inflammatory cells, the eosinophilic extracellular matrix, degenerated conjunctival epithelium. And if you have a true membrane, later on there is angiogenesis and fibroblast activation. And this is what results in the subepithelial fibrosis, sometimes symplepharon, and the resultant dry eye because of the extensive damage to the goblet cells. One of the red flags is if you see this kind of debris in the tear film. If you look at the increased tear film because of the watering that is there, if you see these white debris or dot-like structures seen floating around in the tear film, this is a sign that there is a very severe inflammation. The adenoviral variants, I think this was mentioned by Nikhil. If you see these stuck-on blotting paper appearances, you may want to consider microsporidiosis. Here, it's often unilateral. There may be an exposure to rainwater or infected water or mud. And here, debridement may help, but these will also usually spontaneously clear. As far as the adenovirus is concerned, 70% isopropyl alcohol often does not work. You may need 70 to 85% ethyl alcohol with a contact time of 1 to 5 minutes. So obviously you won't be doing AT measurements in these patients, but if by chance it's been done, make sure to clean it, otherwise it can spread. Hand washing is quite adequate for ophthalmologists, soap is fine, and aerosol spread and fomite spread to be looked for. We've talked about the management, tear substitutes, cold compresses, antibiotics, if there is extensive staining and SPK of the corneal epithelium, oral paracetamol, and you can use topical steroids, like was mentioned by Somshila. You don't want to use it unnecessarily in the mild cases because this may promote viral replication and later on the subepithelial infiltrates may form better, but you don't want to withhold it in a very severe case. I would not use NSAIDs. I think antivirals have no role. Ointments generally not required. Beware of preservatives, and there's no need for using oral antivirals. Oral steroids in a very, very severe case, you may want to consider, but this is very occasional. This has already been mentioned by Somshila, so we won't go there. These are some of the other options with varied evidence in literature. So if you use steroids at the start in every case, you may increase the viral shedding, and this may promote viral corneal persistent. But don't withhold it if you see viral conjunctival inflammation, if you see conjunctival membranes, and the tear sign that I just showed you. Subepithelial infiltrates are usually the bugbear. They form after 2 to 3 weeks. This is an immune response to the viral antigens. This is not an active infection. They tend to be self-limited, and you must allow the body to clear the viral antigenic capsids from the corneal stroma. This can have 3 episodes, usually at 6 to 8 weeks, roughly around 3 to 4 months, and at 1 year. And if you let the body do its job, they will clear in time. But you may need to treat them with steroids if they are in the central area causing visual degradation, if it's an ophthalmologist who can't wait 4 to 5 weeks to go back to surgery. And if you see a confluence of these spots, if they start touching each other, then the reaction tends to increase. There is damage to the Bowmans, and that is when you can get scarring. Typically, peripheral lesions cause only irritation and are best observed with tear substitutes without steroids. But if you have this kind of confluence in the center, touching each other, and you're worried about scarring, you can use soft steroids like loteprednol or fluoroxetine, and they will usually go away within the next 3 or 4 days. So you may need prednisolone if they're resistant to the soft steroids, but you need to taper it very gradually. And in tapering them, the cyclosporine and tacrolimus can help. Treating them with the eczema, there are various reports. You can treat them with PRK with mitomycin C, but recurrences can occur. If somebody comes to you for refractive surgery with these little scars, it's probably better to do a LASIK where the flap will contain them and you don't meddle with them with a PRK. The worst thing to do in these patients is to keep adding medicines. This is a physician who had this. He kept adding medicines. The doctor who saw him, refreshed tears, moxifloxacin, Esivir, and so on and so forth. And then you can get a toxic state, and this is how it looks. Basically, you see the congestion, you see the dry appearance of the conjunctiva, and you see the epithelial defect. At this stage, you do need steroids. Without this, this will not get better. And once you use steroids, generally it all tends to clear up very quickly. It keeps improving rapidly over the next 3 or 4 days. So I think it's important in adenoviral conjunctivitis to understand the pathogenesis. In your mind, define the stages and the intervention strategies for each stage. Protect yourself, of course. You don't want to pick it up from your patients. And today, it seems like subepithelial infiltrates occur in the majority of our patients. They can be managed appropriately if you have a clear management algorithm and you do explain to the patient and ask him to be patient, really. Because if you start steroids at the first sign of a subepithelial infiltrate, and you will find it very hard to wean them off, and the cycle keeps repeating itself. I think I'll stop here. Thank you.
Thank you, Srinivas, for an excellent overview. We'll now go to Dr. Samina Zamindar. She's an ophthalmic quality control specialist and an accreditation specialist as well. She's going to speak to us on how to prevent adenoviral conjunctivitis outbreaks or spread in the clinic.
Thank you, AIOS and Dr. Santosh, for this opportunity. I think all of us have heard an exhaustive exhaustive talks on how to manage EKC, and my job is to bring the focus back on the very simple things. We have all survived through the COVID pandemic, right? And of course, we are now ready to handle any such epidemic of EKC. There were certain things which we learned during the COVID pandemic and which will be very useful during any such epidemic also. So readiness to handle any outbreak. The first and the foremost thing is that there should be a hospital infection control committee, however small your organization is, because any guidelines or any processes or structures or systems you put, but if there is no committee, no manual, no dedicated nurse, and no training, it will not sustain. Standard precautions and staff training is very important. Again, COVID taught us that we can only be as strong as our weakest link. So training should percolate down to each and every member of our staff, and that is of paramount importance. Now, the HIC committee will design the SOPs and ensure implementations of these guidelines, and that is very important. Every department will have somebody who will monitor this. I think all microbiologists have been shouting from the rooftops about the importance of hand hygiene, isn't it? So what did we learn from the COVID pandemic? Isn't it time to introspect and look at what hand hygiene, what importance it has in the context of any epidemic for that matter? Now, there is this talk about the incubation period of 8 days. There was a talk that patient might not be having any symptoms of red eye and the patient is still infective. We will go back to the panel and ask them, is it possible? Don't you think that universal precautions is the most important thing? Consider that every person is potentially infected and maintain standard precautions for each and everything. Hand hygiene, prevention is better than cure, right? We invest so much in a lot of fancy equipments in ophthalmology. How many of us have a sensor tap and elbow taps in our hospitals, an automatic soap dispenser? These are important and simple things which can really stop the spread of these infections. Interestingly, there is a WHO study which shows that there is a direct adherence and accomplishment of hand hygiene steps. There is a high compliance rate, okay. But what about actual disinfecting the palm and dorsum was only 60%. How many of us actually clean the areas between the fingers? Only 10% rub the thumbs. So the compliance is, when compared across professional groups, you will be surprised that it was the least amongst physicians. Why do we don't wash hands? Have we ever, did we ever do a root cause analysis in our own centers that why do we don't wash hands? Are we too lazy, or we are the healthcare workers are bad? No. Patient needs takes priority. We should understand that sinks are inconveniently placed. Do we have a sink at the most convenient place where most of us can go and wash our hands? There is a lack of soap and paper. Hand washing agent can cause irritation and dryness in some of our staff's hands. And we feel that there is a low risk of acquiring infection from patients. So awareness and sensitization of staff has not happened. Hand care for staff is very important. Seeing that they are using protective lotions, they are not having artificial fingernails, and we have to understand that the nails have to kept short. So these simple things are very, very important when we are trying to manage epidemics. I will just share some myths about hand hygiene. Gloves eliminate the need to wash hands. That's not true. It is more efficient to wash your hands with hot water. After washing your hands, you do not need to dry them. Drying is the final and the most important step of washing hands. So paper towels or paper napkins should be there. Very, very important, right? And paper towels are less sanitary than hand dryers. No, that's incorrect. Hand dryers are more hazardous than paper towels. So this is what we do at our center, triage. On giving appointments via phone call, we check whether the patient has a red eye. And like what Dr. Samar said, there is isolation and given appointments in a separate OPD for them. The front desk isolates the patient, encourages hand wash, and there is a hand sanitizer available at every point. There is an OPD coordinator, again fast tracks this patient and sees that they are sent for their appointments directly to the doctor. Refraction obviously is avoided. Too much time in the hospital is avoided and definitely not called during the where the post-operative patients are called for. 1% sodium hypochlorite helped us during the COVID pandemic. It is going to help us during any such pandemic also, right? And we have already discussed the details of how it aids in disinfection of non-capsulated viruses. And surface disinfection has to be done for after each red eye patient. It is of paramount importance. Freshly prepared sodium hypochlorite. Now, freshly prepared means every hour you have to prepare it? No. If you prepare it once, it will last you for 8 hours. You can use that solution for 8 hours. It is safe to use that and it is effective. So we all have now learned how to prepare 1% sodium hypochlorite, right? Typically, it comes in 5% and it has to be mixed with 4 parts of water. And staff cleaning after surface, after checking red eye is very, very important. Patient education. I was glad to hear that Dr. Harbanslal spoke about such kind of public forums and patient education initiatives on the AIS website. And this can be used by all our members. Something which is very, very important, simple, very simple, where any communication or counseling should be as simple as talking to an 11-year-old child. That is the bottom line of any counseling or communication. Do we have such material and can AIOs put it together for all of us? So for our patients and for all patients. Avoid touching eyes, obviously. And 4 steps in biomedical waste management. That is the last part of any standard precaution. How robust is our biomedical waste management? Segregation at source, internal storage, transportation, and treatment. This is our responsibility towards the community also if this is not in place, not just to our patients and to our staff. I think I just wanted to go over to the panel discussion and understand what they have to say. And there are some questions which I also have, which I would like to get it solved. Thank you so much.
I was muted. Thank you, Samina, for your wonderful talk on how to take care of outbreaks in the clinic and how to prevent that as well. So, Samar, would you want to lead the panel discussion? There are a few questions.
A few questions are there. So I think Namrata can initiate the questionnaire. So a lot of questions are there in the chat box.
Okay, so I think, when do you suspect adenoviral etiology in epidemic conjunctivitis? If so, which microorganism do you consider? I think it is generally seasonal and we do suspect it in rainy season such as this. And I can invite Dr. Savitri Sharma and Dr. Nishat both to tell us which of the strains or what etiology have they found, because I'm sure they have huge experience year after year in adenoviral conjunctivitis, and every year at least PCR and investigations are done at especially at institutes to know which strain it is. So Dr. Savitri Sharma, ma'am, are you there?
Yeah, I'm there.
Yes, ma'am.
The question is about non-adenoviral etiology, right?
Yes, ma'am. Other viruses
Before
will-
that, I want to really compliment all the speakers. Everything has been covered. If you ask me what anything more I want to say, I really have nothing, very little that I can say. And in this case, I can say that rainy season, onset of rainy season for us, very much microsporidia we think of. And many times clinicians do ask, is this microsporidia? Is this adenovirus? I think it is adenovirus. So I think these lectures made it very clear how to differentiate between the two. And clinically, you can differentiate microsporidia, because of the raised lesions, you can easily take the scraping and we can see them very easily under the microscope. Just in gram stain or calcofluoride, I have seen even in KOH, I can make out microsporidia. So it's very easy to diagnose, but we have to keep this non-adenoviral cause in the rainy season again. And I did have a PhD who actually looked whether the adeno can coexist with microsporidia, and we did find in some. It wasn't in many, but in some cases we did PCR for both and we could find a coexistence, which is actually, if you go by the natural history, if the organisms are present in the atmosphere and they are there everywhere, there is no reason why they cannot coexist. They can come together. So that has also been shown and we have actually published that. But it's not very common that people look for the coexistence. So I would only think about microsporidia, and others were very rare. The enteroviruses, other Coxsackie, these are quite rare.
I don't know, Dr. Basak sir can also comment on it, but somehow from North India, we've not seen too many microsporidiosis. Nishat can also, comment on it. I don't know in East India. Nishat?
Very good evening to one and all present here, and thank you for giving me the opportunity to be on this forum. Yeah, we do not see many microsporidia. We are doing microscopy also and molecular analysis as well. But from eye specimens, the the detection of microsporidia is very less. And here, especially in daycare centers and of other crowded places, we see a lot of Coxsackie. Actually, in this outbreak, we have not seen, but many times the conjunctivitis cases, they come as Coxsackie and they also come in clusters, most of the times from daycare centers. Also, sporadically, we are seeing HSV conjunctivitis also. So these are the important non-adenoviral causes which we are seeing.
Go to the next question then.
Sir, may I add something in this?
Yeah, please.
Yeah, because it is in the normal clinic these days, there's one religious thing happening, like which is called Kavar Yatra. And I'm getting a lot of patients with microsporidia because they go and they take bath in the dirty water. And these days, those patients are also prevalent because of that religious practice we are doing here. So we are getting such cases these days, which are confused for the viral keratitis, and they're being treated for the viral keratitis, and they come to us in a very bad situation, and we are treating them as microsporidia. So these cases are there in the clinic these days.
Dr. Basak sir, how about East India? Do you see
No. We do not see so much, but once in a while we see like yours. So here, what we are seeing nowadays, it is clinically adenoviral and EKC are the main thing. We have ongoing studies going on with some FDA, I think, phase 3 trial. And we are getting a lot of patients and all are adenoviral positive with their kit. So all are basically adenoviral.
And Nikhil can also tell us if microsporidia is more in West India.
Can I just add before Nikhil, in Bhubaneswar campus, we see lots of patients.
I know, from Bhubaneswar.
Lots, and Northeast, some of our fellows, they tell me about finding cases in Northeast, Guwahati and all.
I think, Namrata, there are a lot of questions. Don't get stuck on one question, Wilson. Namrata, can you hear me?
Yes, I can hear you, sir.
Yeah, so there are a lot of questions, I think.
Next question.
Next question is, what
some
are the
panelist has to add something, they can add,
Sure.
but not keep on repeating, I think.
What are the specific indications for microbiological confirmation in EKC and which diagnostic tools do you recommend? I think this is both
Yeah, this the
microbiology.
microbiologist can answer.
We believe in PCR now. Earlier, I read up the literature. There are a lot of other things like rapid adeno detector. The sensitivity is very low. Already Nikhil said that. I have used that and found it quite useless actually. And PCR is the only one which is the most sensitive and specific. Real-time PCR is now available. So I think people should rely on that.
Nishat, would you?
Yeah, same here. We are also doing PCR. And the antigen detection test we have not used, but the reviews are quite poor, and especially in terms of sensitivity. So we cannot, we being in the government setup, we cannot like waste our resource in something which is not going to be helpful. We are doing PCR for adenovirus and other viruses as well. All the viruses we are doing PCRs now.
Next question, Santosh.
When do you not treat a patient with EKC? I think this was answered, but if you want to re-emphasize the facts.
No, I think you always treat a patient with EKC. At least symptomatic treatment you have to give. You may not be treating the virus.
Copious lubricant actually. Cold lubricant. Shamshila has nicely summarized that actually. Next question.
Next question is, are there any indications for topical antibiotics in EKC, which is the primary antibiotic of choice?
I think Namrata has already pointed out that basically prophylactic use of topical antibiotic is there, and the primary antibiotic of choice maybe not in those cases where you suspect that. Also Srini has also told that cloudy kind of tear you say, and patient gives the history of sticky eyelids and you see matting of the eyelashes. We do start topical antibiotic, but primarily antibiotics in our hospital, we prefer the old regimen like chloramphenicol eye drop twice or thrice daily, but we keep preserve this moxie or other fluoroquinolone group of drug. Namrata, you have anything?
I think I would agree with you, sir. It is better to start bacteriostatic kind of a drug like chloramphenicol eye drops rather than use a fluoroquinolone and then, because if you do start, you're not getting any benefit out of it, and it may also help to this thing resistance.
Right.
Next, Santosh.
Next question is, what are the specific indications for topical steroids and the protocol?
Already pointed out.
So I think, Nikhil, will you take that? I think you did.
Yeah, so normally in very acute phase, we normally don't use steroid as the first line of treatment, but there will be patients who will have very severe inflammation. So if you have very severe pseudomembrane formation, for example, where we know that they are likely to cause scarring and dry eye and things like that, you could peel off the pseudomembrane and use a steroid. You could use a mild steroid to a more potent steroid, depending on how good or bad the case is. And as mentioned, that if there are patients with very disabling central subepithelial infiltrates, you could use a short course of steroid followed by a steroid sparing agent like cyclosporin or tacrolimus. So reserve the steroid. Maybe in the first few days, our immune system is trying to target the virus. If we avoid it that time, the conjunctivitis will recover faster. And to control the cytokine related storm, just like we used to do in the COVID era, it was discussed, we could use steroid a little later, not in the very first few days, because we want the immune system to get activated as well. So I think that would be a good option.
No, I think if the subepithelial infiltrates are in the visual axis and they are, because you don't want them to scar, because if they scar in the visual axis, then the patient loses the best corrected visual acuity. So I would not hesitate to start steroids. And I think there is a study which did compare low dose steroids with the fully potent steroids like fluorometholone vis-a-vis dexamethasone, and concluded that it is better to give more potent steroids rather than give, low dose steroids. I mean, if I have to start, then I will go full on. I will not do a half-hearted thing that you start fluorometholone and twice a day or once a day. If you are giving steroids, then it's a full on. I mean, that is my take.
Srinivas, Tulika, Partha, do you have anything to add?
Sir, these days we are getting patients who are delayed in sorting medical assistance. So suppose patient come with a corneal involvement, which is already using combination of Ciplox-D, because it is very prevalent drug and pharmacists will give the first drug when patient go to with the red eye. So when such patients are coming to you with a corneal involvement and already using a combination of Ciplox and dexamethasone, what would be your treatment for such patients?
Are you asking a question, Tulika? I would never use a
Yes,
combination. If I have to use topical steroids, and I would use it as a single agent. I will not combine it with the antibiotic. Again,
my question is.
Again, you are developing resistance, because topical steroids you will give for a prolonged period of time, and if you give antibiotics also for a prolonged period of time for a viral conjunctivitis, then your resistance is only going to develop. So if you have to use steroids, then it has to be a separate. It cannot be a fixed drug. I mean, at least I would not want to use it as a fixed drug combination. Dr.
Definitely, ma'am. I just wanted to ask that patient comes with this combination to the clinic because they're already using over-the-counter Ciplox-D. So what would you prefer? Like, would you like to stop the medication and shift the patient to the other plain steroid? Or would you just like to stop this thing and go for the surface steroid like fluoromethanol?
No, sir, would you want to answer that?
These are some difficult, we do not like to use the combination drug, but again, if you are use it for a shorter period of time, if the patient is saying that he's getting better and better, then you can continue the same combination for another 10 days or 2 weeks, and then you can switch over to single steroid regimen. But it is all depends upon what is the finding at that point of time and what do you want to see the response from the adding steroid or avoiding it. Because these are dilemma situation. You can stop the whole lot of thing. You can simply start on topical lubricants frequently with cold compress and see the response after 2-3 days.
Or any wise words? You have finally appeared. Unmute.
Partha?
Yes, what I have would as of now, the antibiotics definitely is playing a role, but only in the mucopurulent conjunctivitis, which comes on as an add-on after the viral. But I would like to ask Dr. Samar Basak and the other speakers that would you use povidone iodine and dexamethasone in these patients?
No, we had tried earlier, but it is very difficult to make the right concentration and it is too much irritant. I have given in my eyes 1% povidone iodine and dexamethasone when I had the same about 4 years back, but that is so much irritating one. So that is a good idea. When you are seeing the patient, you put a drop of some anesthetic agent and put a drop of 5%, because that is readily available. You do not have to dilute it properly. And once a day, what Shamshila has, that is also sufficient to reduce that actually helps. But probably time will come that 0.1 to 0.5% povidone iodine along with dexamethasone 0.1% will be available in commercially. A lot of studies are going on across the world.
So as of today, we are not using povidone iodine and dexamethasone. What about cyclosporine and tacrolimus, which is very freely available?
Shamshila.
Yes.
Both of these we usually would use when you're either when you're tapering steroids. For example, the cases that Dr. Namrata pointed out, you have nummular keratitis, and then you need to taper and stop steroids, and the patient continues to have recurrent episodes. So the next time round, you might treat it for the maintenance phase with cyclosporine or tacrolimus.
So do we start with tacrolimus and cyclosporine?
No. You would start with both, because cyclosporine is going to No. If it is recurrent and nummular opacities are there, then you would perhaps start with both because cyclosporin takes 2 weeks to act. And
Okay.
you would eventually have to taper steroids. So you start both, then taper steroids once it gets better, and then cyclosporin over a prolonged period of time can be tapered again.
Yes, I agree. When I said not both, I meant not.
You meant primary.
Both together.
Yeah, you can start both together.
So I have a question to other panelists. Right now, it comes to my WhatsApp. I had operated a patient 2 days back, cataract, phaco surgery. Now he sent me the photograph of the eyes. It is actually a conjunctivitis. So how do you treat this patient now?
So
He sent me the photograph just now in my WhatsApp. So this is also a big problem. If you read the WhatsApp group, these are the same problem. In every house, whenever you are doing cataract surgery or other surgeries, you are doing other surface procedure or whatever, on top of it, there is having. So I have asked the patient to come tomorrow and show me, then I will decide. But what is the because the patient is getting steroid for cataract and also lubricant and also antibiotic.
So that should be fine. I mean, fortunately there is no adenoviral endophthalmitis.
endophthalmitis has not been reported, I think, ever. I think there was this question also in the chat group that can endophthalmitis occur? So we've had one who for one patient for whom we did LASIK has now developed on the 4th day has now developed conjunctivitis.
Well, I also had a patient about a week back, absolutely similar, LASIK done, and then developed acute mucopurulent conjunctivitis after, of course, possibly adenoviral. And it was a very, very difficult situation in which there was very high inflammation and the flap was it was quite edematous, and ultimately with steroids and with a good coverage of steroids, it responded well. We thought we might lose the flap also, but it has responded. There are a lot of epithelial nests all around, and still a lot of inflammation is there after about 10 days of treatment, but the patient is healing and the flap is still in position. I think here is one situation where steroids play a very important role.
To the next question, that is, I think this is for Srinivas. Is there any role for surgery in pseudomembranes?
I think basically you have, pseudomembranes indicate that the inflammation is quite severe. So the go-to medicine here would be steroids. You can't get away from that. But if you find a lot of corneal epithelial damage in the area of the pseudomembrane, what I'm saying is the superior, and if you have the superior half of the cornea which is being hurt because the membrane is rubbing on it, then I guess it's okay to take off the pseudomembrane. But if you just take it off and treat that as the treatment, it's not going to work. You start a lot of steroids and then you can remove it if it is causing some corneal damage. Even if you didn't, once the steroids kick in, it will go away by itself.
The last question, I think, has been adequately answered. How do ophthalmologists avoid getting infection of VKC themselves? So
Samina has already answered that.
Yeah.
Those questions.
If you have any more questions from the social media, then you can go ahead. There are some questions that Sunil has posted from social media. If any of these are not answered, maybe each one of you can
most
answer.
of them
It's
have
on the
been.
chat. Should we abandon elective intraocular surgeries until epidemic settles is one question. Any thoughts on that?
I don't think so. We need to abandon any surgeries, elective or emergency, because
On
of
operating mass cases in an epidemic, in a camp situation.
One question maybe we could answer this, that if a patient has had EKC and then has healed, what is the right time that we should operate on cataract or a surgery to be done for the
I think Nikhil can answer. He gave it in the slide also, his answer.
No, one of the problem if you have to do cataract surgery is that if you have infiltrate, sometimes the keratometry may not come properly. But the other thing that can happen is you can give them steroid, the infiltrate will go away. You can take your measurements, do the surgery, suppose, and then warn the patient that after 6 weeks, when you taper the steroids, they may again get the infiltrates, their vision quality will go down, and maybe you'll have to maintain them with cyclosporin, but the quality of vision may not be good for 6 months to a year. So if the cataract is dense, I don't think we have an option where things can wait. I think patient satisfaction will be poor, if these infiltrates hang around post-surgery that way. That is what I feel. So maybe we can tell them to, postpone it a little bit longer. But if it's a mad cat, advanced cat, I think we have to do it and not really stop doing it.
A corollary to this one is if it is not a mad cat and the patient has had EKC, and would 3 weeks be a good time after which we can?
No. I think 6 to 8 weeks would be a good time, because like Nikhil mentioned in his own presentation, it has a biphasic kind of a presentation. So you have the initial 3-4 days, which are very severe, and then you may have another phase, which may, happen. So I think ideally one should wait for at least 6 to 8 weeks if you want to do cataract surgery in these cases, and also see if there are any subepithelial infiltrates or not. If they are there at 8 weeks also, then obviously you can't do it.
But also there's a component of dry eye following viral conjunctivitis for a prolonged period. Goblet cells will all be lost. So
Yes, absolutely.
one question is, does use of steroids increase the risk of developing subepithelial infiltration? Increase the risk is a question.
Yeah. So this is what was also being discussed in WhatsApp.
Yeah.
Chat.
What is the answer? No, right?
No, you can't say no, because it does increase viral shedding, the topical steroids, and there are other reports which say that it does not, but most of them do tend to believe that it increases viral shedding. And so the incidence of, but having said this, there are no studies which have prospectively evaluated steroids versus no steroids and then seen the subepithelial infiltrates. So those longitudinal kind of studies are not there. But theoretically, yes, the viral shedding may increase because of topical steroids.
One question is that, do we need to examine each patient on slit lamp if the patient doesn't have visual symptoms? Examining on slit lamp means that, of course, you need to sanitize every time you do that.
That is the reason, but you have to see the patient.
Have to see, you might have these infiltrates in the periphery. They may not be there in the center. So the patient doesn't complain of decrease of vision.
So torchlight examination doesn't say much. So you have to differentiate from other pathologies also. So you have to see under slit lamp, and with what Shamina has said that regarding the protocol of hand washing. That's why isolation is very, very important for this kind of patient, temporarily for this period when whatever is happening in.
But in any case, if you suppose there are peripheral exudates, you delay the treatment for 3-4 days, how it makes any difference?
I
You don't want to examine immediately, and if the patient becomes all right and the discharge decreases in 3-4-5 days time, and patient can come back.
One problem is that we might.
Patient has got no visual symptoms and the cornea is bright and shiny on a torchlight. Why we need to examine on the slit lamp?
No, you need to, sir, because the patient may or may not have adenoviral. Maybe the patient has a herpes.
Whatever it is, even if nothing is going to happen, any viral disease in 3-4-5 days time.
No, but
what serious lapses will happen in 3-4-5 days time? Nothing. I mean, whatever we have talked and discussed and listened to all of you. I mean, I'm a general ophthalmologist, I'm not a specialist. Even if there are SPKs or some exudates or something over there, you're not going to start these threats. In any case, in any viral disease, there's hardly any role of any antiviral medication over here.
Just like
if the patient is having frank, watery discharge, very clear-cut conjunctivitis, and it has got no diminution of vision, and the cornea is bright and shiny, I think we can definitely delay the examination on the slit lamp. There is no hurry to rush to the slit lamp again.
I think it also depends on.
If you do not have a really antiseptic protocol in place, where you need to clean the slit lamp every time.
There are just a few different.
I don't even touch the eye of the patient at all. I don't touch the lid. I don't touch the patient.
I completely.
In case.
Completely agree.
Yes, ma'am.
We should do it in as rapid time as possible. But the few differential diagnoses coming from where I practice, one is uveitis, of course, anterior uveitis, which the cornea will look fairly clear. Patient will not complain of vision symptoms, and you can only see that on slit lamp. And second is you can have a herpetic epithelial dendrite, which may be in the periphery. And these are all vision-threatening conditions. So if you leave them alone for a few days, then you have a worst-case scenario. We've had that in the past. So
yeah, even if uveitis treatment is delayed for a day or two, makes no difference.
No.
So I had a friend who called me up. His wife has used to keep on getting recurrent uveitis. She called me on the phone. There's a redness. I said, give the antibiotic. If by evening you develop the conjunctivitis, then continue with the treat on the viral line. If you don't, then the next day you start this red eye drops. It's fine. Next day started this red eye drops. So what I'm saying is, I mean, it's not must to examine on the slit lamp. And if your proper protocol of hygiene is not there, I mean, I may be wrong, but it is not must to examine all the patients on the slit lamp unless you feel there's a very strong reason for you to examine. Some of them I do examine, but majority of them, it's very clear cut what the family history, brother has got, the wife has got, husband has got, everybody has got in the family. I think there's hardly any need for that.
So you are the only one who's differing in this context. Rest, all of us agree.
Because I'm a more practical man and seeing more of a.
So in this context, there is a question like, how do you treat if AKC in a child less than 1 year?
You are asking me?
No. Question
not
to the
examined.
panel. I'm reading the question from the panel only, from the chat box only. So the same thing, your thing that we have to see under torchlight only, and probably with some magnifying devices. So how do you treat? That is the question asked by Pallavi, I think someone. Chat box.
So I think less than 1 year don't have to actually treat, just maintain the general hygiene. I mean, you don't have to even bother even putting the antibiotic drops in them.
So why
No, I
should
remember
treatment
that,
take for less than 1 year? I mean, it will be the same.
No, in one of our Cornea Society meetings, PGI Chandigarh, they presented they had you can say a big outbreak in their premature wards and, their ROP patients,
Right.
because
exactly.
one you examine ROP and the doctor had conjunctivitis and all the infants had got EKC, and it was quite difficult to treat and examine, and how they managed that epidemic is something, that she described, which was quite a task, and the family members are also very unhappy that, the infection is spread from the hospital environment. So I think we need to take care, especially when we go in these neonatal units, and to be careful that at least we don't spread it to them.
Right.
Absolutely.
Yeah, just I wanted to say something about the same thing. Dr. Subhadra, who looks at these ROP patients, she had this kind of an outbreak. And the solution she found was just to have new speculum for every patient. No sharing at all. This she mentioned. And of course, the hand hygiene and other things have to be done. But the speculum, having large number of speculum in the OPD helped her.
And last question, I believe, what is the role of ganciclovir or antiviral medications?
No role.
Somebody has asked this question. Many have asked this
No
question.
role of topical
No
or
role.
systemic antivirals.
None.
This virus is not, the antivirals we have are not effective on this virus. It's a different group altogether.
So
And also 70% alcohol is not effective for this virus that has been mentioned. So that's why we need the sodium hypochlorite.
Yes.
I had just one question. If we are talking about not checking the patient on the slit lamp, would you want to check vision for this patient?
Vision I do check. Vision, all patients are checked, but NCT and all I don't do. And no refraction, nothing, no dilatation, and send the patient off. Only instruction to all the family members is one, do not touch your own eyes. If you don't touch your eyes, you won't get it. And if any time feel like touching your eyes, go and wash your hand. If you got in the one eye, only put the drop or anything in the one eye only, don't put the drop in the other eye. No prophylactic. If the small kid, old lady, anybody, don't put anything inside the eye if you don't have infection. Don't do anything. Just don't touch your eyes.
It's also the respiratory secretions, especially from pediatric patients, because they have no control over. The one time I got conjunctivitis in my life was from an ROP baby.
So that's rare. Most of the time it is by contact. I mean,
it's by the respiratory secretions actually, because I don't touch my eyes and never touched in the clinic. So we always, all of us, I remember Dr. SH also had conjunctivitis.
Yeah, very bad.
Also treats retinoblastoma. So It's also
I got it from a child, actually.
No,
Yeah.
that's all possible. Yeah, of course.
yeah, it's the secretions as well, the respiratory
Yeah.
secretions.
But touch is the commonest mode.
Correct, absolutely.
So I think we have come to the end of this webinar. If any of you have any concluding remarks, that will be great. Otherwise, I'll thank all the speakers.
My only submission is that one of you should take a job of preparing do's and don'ts for the patient, which we can put up.
So we have already done that. It is in the draft stage. I'll share it with you. We have already done that.
I've not seen it.
I will send it to you.
Which we request all of us to put on a social media platform and other places so that it gets widely circulated. So one of us standardize do's and don'ts for the patient, and which we can post on the various WhatsApp group. And if somebody wants to get it printed and keep in its clinic, they can do it the same. And if we can send it to the various newspaper and media houses, if they want to pick up, they can pick up. If they don't want to pick up. So at least if we can make do's and don'ts for the patient's education point.
Yes.
So Santosh will take the responsibility and get it ready.
Yes, sir. We have already got
already
the
done
first
there.
draft done. I will circulate it to all the
So
panelists.
circulate and give it to all of us. And we request all of you to put into your Facebook and other places so that it will automatically get circulated.
Yes, yes.
So with that, Samar, you want to say something?
No. I am for that only, that it should be wide. Whatever discussed, very good point, only do's and don'ts and bus.
So with that, we come to the end of this session. And I thank all of you for enlightening us. And I'm sure slowly more and more people will watch it. And we are, most of us, on the right track. And thank you very much once again. And bye-bye. Good night.
So we had the highest viewership, and I also want to thank Ajanta Pharma for the sponsorship, Sunil for the technical help, and Kripal for being the backbone. Thank you so much.
Thank you.